From confirming the death of a palliative patient, which essentially means he was end of life, and the purpose of the treatment was just to make him as comfortable as possible, so no active treatment. Always think of the family and whether they would want to be contacted. So usually we like to be prepared and ask beforehand if we see that the patient is getting unwell, would the family like to be called 24/7, or only in the morning, that sort of thing. And that's really, really important to keep in mind. So for this gentleman, his wife was already present, and I think I've mentioned this in another video already, but there's different protocols for confirming death. They all include 5. So you feel for a pulse, you listen for heart sounds, for breath sounds, you look at the pupils, whether they're reactive, and you assess if there's a reaction to pain as well. So this would be something like squeezing the trapezius muscle or the nail beds. And then once you do that, you have to fill in a document confirming the death and the time of death. And that's pretty much it until the next couple of days, where you usually receive a letter which you pass on to the team that knew the patient about the actual cause of death and other details. So this is my third night of the week. I've got one more left because we do 4-day stints and then the 3-day weekends, so 4 and 3, which I think is a decent amount because you get pretty tired after the 4th day. I thought it'd be nice to talk about a few cases that I was called for during the night. The type of things you'll be called for and what to do about them, the things that you need to think about. So one patient that I was called about was admitted for sort of a general cognitive decline and walking difficulties. He wasn't managing well at home, and 2 days before he'd had a catheter inserted for urinary retention, so he'd had a retention over 500 mils. And so last night he wasn't agitated, but he tried to get up to urinate the normal way, and he tried to pull out his catheter. So the nurses called me telling me that he was bleeding from the meatus and that he was agitated. So I went to see him. He was pretty calm, he was not in pain. With regards to the catheter, so it looked like it was still in place. There was some blood coming out of the meatus, but a very small amount that basically stopped with compression. So I just had a couple of gauzes and you apply pressure, wait for a couple of minutes, and that was enough to stop the bleeding. So that was a good thing. Catheter had some haematuria in the pouch, so it wasn't frank red blood, but it was between rosé and frank red blood. There's a grading of colors that can be helpful with haematuria, because very light colored sort of tinted urine is not the same as frank red dark blood. So it's helpful to use that color scale to have a more sort of standardized idea of what level of haematuria there is. The urine was still free flowing, and when I tugged lightly on the catheter, it looked like it was still in place, so we didn't have to recite it. And haematuria is a broad topic, and there's lots of parts to it. In terms of the diagnosis, first of all, you can think of infection, malignancy, trauma, like we had today. For him, there was an obvious cause to his haematuria, so we didn't necessarily have to go further. But you definitely, if somebody presents with haematuria, you need to keep in mind the 2-week wait pathway in the UK. So there's specific cases where you will refer a patient directly to be seen urgently, so within 2 weeks. And if I recall correctly, for visible haematuria, because you can have non-visible as well, but if it's visible blood in the urine, if they're over 45 years old and they don't have a urinary tract infection and they've got persistent haematuria, that's one indication. And also if they have been treated a UTI, and it's still not resolved. It's persistent bleeding. For non-visible hematuria, it would be somebody over 60 years old with non-visible hematuria plus pyuria, which is white cells in the urine, or symptoms, so like dysuria. But that's something to keep in mind. When you've got a presentation of hematuria, you don't know the exact cause, so it could be multiple things, and it depends also on the clinical examination. So if a patient has, severe abdominal pain, you're thinking maybe ureteric colic, amongst other things. If you're going down the line of malignancy, then we talked about the 2-week wait and them needing further investigations like cystoscopy, etc. But for my patient, it was pretty straightforward. There was a clear cause for the hematuria. So once the bleeding has stopped and I was happy that the catheter was in place, the patient was hemodynamically stable, he was calm, he was not in pain. The other thing that you may want to consider is if there are some clots in the catheter bag. So sometimes you'll get some bleeding, sometimes you can get proper clots in the bag, and that can easily block the urinary catheter, and obviously that's a problem. So if you're concerned about blockage of the catheter or you see clots, especially after a traumatic injury, then you may want to consider irrigation or washout. The way I understand it, irrigation is more where you're getting water to slowly run through the system of the catheter in order to clear out any debris, any clots. And washout is a similar thing, but it uses slightly more force. So usually it's done with a 50ml syringe, and water is sort of slightly forcefully pushed in and retracted quite quickly from the catheter in order to create a bit of suction and pull out any clots, any debris, and clear the catheter for the urine to flow into the bag. In my hospital, we have urotainers, so that's an irrigation system where you basically have a bag of 50 mils, you connect it to the catheter, you lift it above the patient, it slowly flows through, and then you put it down again, and gravity makes the water come out. And that usually is good enough to help clear any blockage. If that doesn't work, then you can think of putting in a 3-way catheter to do proper sort of continuous irrigation. So that was it for my patient, also I thought. And then I was called again in the early hours of the morning because he pulled out his catheter entirely with the balloon still inflated. So when we insert a catheter, we inflate about 5 to 10 mils of water into a balloon that's at the tip of the catheter, and the balloon fills up and stays in the bladder, and that allows the catheter to stay in place. So if you pull slightly, the balloon sort of blocks it in place. If you pull very hard, then the balloon can actually go through the ureter and out, but it's very traumatic, very painful. And so I was called because he was bleeding quite actively from the meatus. I went to see him and he was still bleeding, but again, compression was enough to stop the bleeding. Now, if it's a superficial sort of injury, usually compression is enough. If the bleeding comes from a deeper site, so the bulbar region, for example, that's an indication for catheterization. Now, because the patient was in retention 2 days ago anyway, a catheter was indicated. So once the bleeding had stopped with compression, the patient was surprisingly comfortable for somebody who had pulled out a 7 mils inflated balloon from his bladder. So using Instilogel, I inserted an 18 French catheter because he'd had the 18 French before. So when I say 18 French, it's just the size of the catheter. The bigger the number, the larger the diameter. Usually for a man, I don't remember the exact readings actually, but for women it's usually around a 14 French, and for males it's around 16, sometimes 18. What I was actually taught by a urologist is that if a patient is known to have a large prostate, sometimes it's more helpful to have a larger catheter. It sounds pretty counterintuitive, but the reasoning is that if you use a small catheter, well, with a smaller diameter, and there's an important blockage with regards to the prostate, it's just going to bend and fold and not be able to go through. Whereas if you use a bigger catheter with a larger diameter, then it's sort of more sturdy and it's able to go through that point of resistance. So that worked really well for him, and his urine, it was slightly rosé, so slightly pinkish, but there was no frank blood, there were no clots, so there was no indication to irrigate further. That's how I left him this morning, and I handed over to his regular team, so they're going to review him this morning as well. But hematuria is definitely a common thing that you can get called for on a shift, and I suppose you need to think, what do you need to urgently do and what could wait for the next day if you're on a night shift. That's pretty much it for now. I can't think of any other interesting cases, but yeah, I've got one more night to go and then I'm off for 3 days. Well, I count it as 3 days because if you work Friday night, if you work Thursday night, then Friday morning you hand over to the team at around 8:30 or 8 o'clock, and then you're done you're supposed to be sleeping during the day because you've been awake on your on call. So it doesn't really officially count as a 3-day weekend, but it feels like it. I hope these chats are useful and it gets you thinking about the common presentations you can get on the ward, and that, you know, at the end of the day, as long as you follow your basics, make sure that your patient is stable with regards to their OB, treat anything that's urgent, take your time, think of differentials, do a proper clinical examination. Before you prescribe anything, make sure that you look at allergies, you check their medications for any contraindications, and you think about what investigations you need and why you need them. Then you'll be okay. And you just pick it up as you go along, bit by bit, you know. And we learn stuff on every shift, every night shift, every day shift, and that's why they're so good for learning, and that's why they can be stressful, because you're out of your comfort zone. But that's the best way to learn. So I think, I mean, it's easier said than done, and I think we all struggle with a certain level of anxiety maybe before night shifts. The more you do them, the more you get used to them. Like, even I can tell on my first night shift of the week, I'm much more anxious than on my second or third or last night of the week, because I've just gotten used to it. We just have to be patient with ourselves